and thanks for joining us for another of our seminar series from the Philadelphia Regional Center for Children's Environmental Health. Today, we have a center member who is talking with us about primary lead prevention. Noah Buncher is a general pediatrician with the Department of Primary Care at Children's Hospital of Philadelphia. He's the former medical director of the lead clinic at Boston Medical Center and former pediatric environmental health specialist at the Region 1 Pediatric Environmental Health Specialty Unit in New England. Dr. Buncher's research focuses on developing novel tools and evidence-based strategies for the early detection and prevention of childhood lead poisoning. By leveraging the technology of telemedicine, his current work aims to create effective and sustainable primary lead exposure prevention interventions for high-risk children and families by performing remote lead inspections of the home and connecting families to appropriate community resources. Welcome, Dr. Buncher. Please take over.
Thanks, Marilyn, and thanks everyone for joining on this rainy Wednesday morning. I'm going to jump right into it because I have a lot of material to cover, and hopefully we'll have some time at the end for questions. So my objectives this morning are to define childhood lead poisoning, to understand lead screening recommendations, describe public health significance of pediatric lead exposure and the need for innovative care delivery models. And then lastly, of course, is to summarize the structure, goals, and key components of the Take the Lead on Lead telemedicine-based clinic. So why not get started with this super busy table here that looks at the screening recommendations for pediatricians during sort of our primary care visit. So who and when to screen for lead is somewhat of a confusing topic for the general public and pediatricians alike. And this is true because guidance comes from various sources. There are medical associations such as the American Academy of Pediatrics. There are federal agencies like the CDC and state agencies and public health departments. They all have slightly different recommendations. And so, as I said, this slightly, or should I say super busy table is an image of the American Academy of Pediatrics periodicity schedule. So it's a complete list of recommended preventive pediatric care beginning at birth, extending all the way up until about 21 years of age. And this table really includes everything from lead and anemia screening recommendations to blood pressure screening and screening for things such as autism and depression alike. So the AAP recommends, in terms of screening, a lead risk assessment using a questionnaire that be done as early as really 6 months of age and annually through 6 years. If the questionnaire is positive, the recommendation is then to perform lead screening using a venous blood lead level, which is really the gold standard, or a capillary lead level. And screening can begin as early as 9 months. The main problem with this method is that screening questionnaires are not accurate for identifying children with elevated lead. And so many kids are likely falling through the cracks and not being screened appropriately. Lead screening is required for all kids aged 12 and 24 months enrolled in Medicaid insurance. So Medicaid eligibility is thought to be an independent risk factor for lead exposure, as many of these households live in lower socioeconomic communities with a higher potential for lead exposure. And then for kids not enrolled in Medicaid, requirements for blood lead testing vary by state. So some states have universal or targeted lead testing requirements for kids at 1 and 2 years of age. So for example, New Jersey is an example of a state with universal screening recommendations, whereas Pennsylvania has different screening recommendations depending on the county that you live in. Ideally, we would have federal law that would require universal screening for all kids at 1 and 2 years of age to simplify these methods, or these recommendations rather. The gold standard for lead detection is through measuring the lead in blood, and this is what we essentially call a venous lead level. Capillary testing is slightly less accurate, as it can overestimate the lead burden in blood due to contamination either from the surface of the child's skin or in the sample collection process. Capillary lead levels that are over 3.5 micrograms per deciliter, the reference value should always be repeated through a confirmatory venous sample in a timely manner. So once we've screened a patient for lead, the question is, how do we interpret those results? And so it's important to remember that the presence of lead in a child's blood is an indicator of past or current exposure and absorption, but there are limitations in how we can interpret these individual results. So when we obtain a venous lead level, what we're really measuring is red blood cell lead content, not plasma lead content. And plasma is actually the more significant value because lead in plasma in our blood is more readily able to leave the blood and enter adjacent cells. So the venous lead level that we're getting in clinic is really an imperfect proxy that's actually quite removed from tissue cell lead, the site where the majority of toxicity occurs. All of this is to say that the blood lead value is really a measure of potential toxicity because it's correlated with it's correlated with various adverse health outcomes in large groups of children, but it's impossible to say how any given lead level will impact that specific child being tested. So the CDC announced in 2021 that it was lowering the lead reference value from 5 micrograms per deciliter to 3.5 micrograms per deciliter. So I want to draw your attention to the graph on the right here. So we can see that the CDC has used a variety of terminology and definitions for interpreting lead over the years. So for example, in the 1970s, a lead level of 40 was considered quote unquote undue or increased lead absorption. And it wasn't until 2012 that the CDC adopted and implemented the reference value terminology. So the most recent reference value was determined from the NHANES survey data collected between 2015 and 2018. And it's based on the 97th and a half percentile of lead distribution in kids aged 1 and 5 years. So again, to say this another way, about 2.5% of US children age 1 to 5 have lead levels at or above 3.5 micrograms per deciliter. In 2012, that number was 5 micrograms per deciliter. So we're improving for sure, but we have a ways to go. The reference value is really a statistical definition that can be helpful for surveillance purposes and, of course, to prioritize public health interventions. But the bottom line, again, is that there's no safe level of lead, and even low levels, so under 3.5 micrograms per deciliter, can adversely and irreparably impact a child's neurodevelopmental outcomes. Let's shift gears a little bit and talk just briefly about environmental justice. And so this is a map of Philadelphia by zip code and looking at blood lead levels. In the 8 zip codes in red that we can see mostly centered in West, Southwest, and North Philadelphia, these are zip codes where more than 10% of tested 3-year-olds had an elevated lead level of 3.5 or greater. This data comes from 2022. It shouldn't come as much of a surprise to most of us who have been in this space for a little while that there's a strong correlation between zip codes with high rates of elevated lead and high rates of child poverty and minoritized communities. This graph from 2011 to 2022, looking at Pennsylvania children with elevated lead levels, shows decreasing levels across all racial and ethnic groups. Again, a huge accomplishment and something that should be celebrated. However, disparities still persist. Non-Hispanic Black children consistently have the highest rates of elevated lead levels, dropping from 15.33% in 2011 to 7.3% in 2022. Still above all other groups and about 2 times greater than non-Hispanic white children. So the idea of launching a telehealth-based lead inspection program began, as all great ideas did, with the very beginning of the COVID-19 pandemic. We saw decreased lead screening rates and increased lead exposure risks as a consequence of the pandemic. So on the right here is a graph taken from the CDC's Morbidity and Mortality Weekly Report showing really a precipitous decline in lead screening by month in 2022 as compared to 2019. Nationally, we see lead screening rates fell by an estimated 34% during the first 5 months of the pandemic in 2020. In my general pediatric practice, we very quickly pivoted away from in-person visits and to telehealth. With this change, my colleagues and I found telemedicine to be a very crude and perhaps challenging way to practice general pediatrics, but also uniquely suited to my environmental health patients, a specialty that's really centered on impacts of home and community factors. Rather than having to rely on sort of families giving you a report of the home condition, I had this amazing window into their home, and I could actually use the camera on the back of their smartphone to see their home environment. In my lead clinic, many of the common counseling that I used for families, like frequent hand washing, cleaning of surfaces and toys, and removing contaminated shoes and clothing before entering the home, were also infection prevention strategies for COVID-19. So there was a lot of overlap between environmental health mitigation and infectious disease prevention, which this image shows. So again, in 2021, the CDC lowered its reference value to 3.5, but in many state lead programs, they were slow to adopt this new reference value. And at that time, the state of Massachusetts, where I was living and practicing, required a lead level of greater than 10 to perform a home inspection and to qualify for case management. And so few mechanisms really existed to support patients with a lower but still detectable blood lead level. And so we developed a virtual model to improve timely access to home inspection and resources for families who would otherwise not qualify. So the initial Take the Lead on Lead study was done over a 1-year period in 2023 through 2024 at 2 large urban academic medical centers, Boston Medical Center and Boston Children's Hospital. Eligible patients were between 9 months and 5 years, kids with lead levels between 2 to 9 micrograms per deciliter found on routine screening were eligible. Patients were referred by their primary care provider. For the virtual home inspection, participants were guided through the interior and the exterior of the home, again, using the cell phone's rear-facing camera. And of course, there was a strong emphasis placed on high friction, high touch surfaces, windowsills, door jambs, banisters, door frames, porches, and anywhere really where we saw deteriorating paint. On average, these inspections lasted about 15 minutes. Families received counseling at the end of the inspection based on our findings, and also lead mitigation kits. So these kits contained qualitative lead dust swabs, so families can swab for lead contaminated dust in real time during the visits, and we could help them interpret results. The kits contain lead specific cleaning material, paper towels, rubber gloves, educational material. These are just a few screenshots of sort of deteriorating paint and possible sources of lead that were found in participants' home during the virtual inspection. After the initial consultation, so the inspection, the education, the sharing of the lead mitigation kit, we would transition families back to their PCP for continued lead surveillance and management. So the results of this study, we were able to enroll 35 children from 33 families. who participated across both of those sites. The majority of participants were Black, publicly insured, and lived in homes built before 1970. Much like Philadelphia, Boston has a very old housing stock, and so this didn't come as a surprise. The average child age was 3.2 years. At the time of referral, most participants had blood lead levels between 5.1 and 10 micrograms per deciliter. So 37.1% had a lead level in that range. So again, the majority of referrals were children with lead levels above the reference value, but none of these children qualified at the time for public health interventions, including a home lead inspection. Lead dust testing and the lead mitigation kits were distributed to 77% of families. Virtual home inspections were conducted in 80% of families, and 71% of these cases did show potential for lead hazards. At the time that we collected data, 80% of kids had repeat lead levels, and over half showed a greater than 20% decrease in lead levels. Of the families who completed a post-participation survey, 100% felt that their questions about lead poisoning were addressed and that they received useful education resources. Among those with a virtual home inspection, 95% said it helped identify possible sources of lead exposure. And so at the conclusion of this study, we really felt that we're able to not just successfully operationalize and support early identification and prevention of household lead exposure among high-risk families who wouldn't otherwise qualify for public health interventions. But we also felt that it enabled sort of detailed residential lead identification with high levels of participant satisfaction. The direction we knew we wanted to go in the future was extending really these same services to a younger population. So primarily thinking about kids under 9 months who theoretically haven't yet been exposed to lead, right? Because they're not yet mobile, and in most cases have yet to undergo blood lead testing. And so if we fast forward 2 years, I've now completed the version of the Take the Lead on Lead project here at CHOP. And though the crux of the project remains the same, there's some key differences I want to highlight. So in this project really, I think the main difference is that we really wanted to focus on primary prevention. And so you'll see how we did that. And so we recruited 2 cohorts of kids. So the first cohort was newborns at high risk for lead poisoning. So the main risk factor that we looked at was Medicaid insurance as the primary risk factor. And then the second cohort were kids between 1 and 5 years of age who have a history of lead exposure, right? But a lead level below 3.5 micrograms per deciliter. So again, unlike the project in Boston, where the majority of enrolled kids had actually high lead levels, 100% of participants in this study had lead levels below the reference value. So similar to the project I described, we conducted telehealth-based home lead inspections and education visits with participating families. You can see the schema, the basic schema on the left here. We originally intended to do recurring home visits, Q3 to 6 months. However, this was later revised to just doing a single home visit. We provided families with home lead testing and mitigation kits, referrals to community resources when indicated, and evidence-based recommendations. We ended up recruiting 52 families. 27 families ended up completing the virtual home inspection, 12 in cohort A and 15 in cohort B. I think the best way to give you a sort of the flavor and a look at what these virtual inspections felt like is to present an actual case of one of the participating families. And so I'm going to talk about the case of this 15-month-old female who was enrolled in the project. She has no significant past medical history aside from a history of lead exposure. So she had a lead level of 1.1 that was detected on routine screening at her 9-month well-child visit. And so she was recruited into cohort B. Through our initial intake and history, we learned that the family lives here in Philadelphia in a pretty typical row home built in 1919. The family rents and have lived in their current home for 7 years. This 15-month-old does have an older sibling, but she's the only child in the home who is under 6 years of age. She doesn't spend a significant time outside of the home, and she is not enrolled in daycare. There are no adults in the home that work in any sort of high-risk lead occupation, so things like construction work, plumbing, auto mechanics. No adults in the family worked in any of those occupations. The family did endorse using a ceramic pot for cooking, which is something we always ask about because of the known risk of potential lead components in some of these pots. The mom purchased this pot on Amazon, but she denied using any imported herbs or spices, and does not use any ethnic or cultural makeups. The child eats a pretty age-typical diet, and drinks mostly milk and bottled water. On social determinant of health screening, the family did identify childcare resources as a need for them, and we did provide these resources at the end of the visit. As many of you already know, the Philadelphia Lead Paint Disclosure and Certification Law that was implemented in 2020, I believe, requires landlords of homes built before 1978 to provide a certification that property is lead-free or lead-safe before it can be rented, or need to obtain an exemption if the home is built after 1978. Philadelphia has sort of an open database of lead certification, and so using this lead database, rather, we found that this child lives in a home that is actually not lead certified. So here are some images we collected from the virtual home inspection. So on the far left, we can see some peeling paint. This is above the bed of the older sibling, a large area of peeling paint. The middle picture shows the clay pot that I mentioned that was purchased on Amazon. And then the image on the far right are results of lead surface wipe testing of the clay pot that we actually did interpret as being mildly positive. You can see sort of this orange reddish spot or hue. I'm not sure if you're able to see my pointer here that I'm waving in front, but that does indicate mildly positive risk for lead contamination. And so during the visit, we also swabbed the chipping paint that we saw above the bed, and then some vinyl blinds that were in the home that are not pictured here, and both of those were negative for lead. So from the testing that we did, the environmental history we obtained, and the virtual inspection, we're really able to provide this family with some good counseling and lead mitigation recommendations. So first, we talked about, unfortunately, probably stopping to use the clay pot, just given the risk for lead contamination. We talked about covering and blocking several areas that we identified, some of the areas of peeling and chipping paint that we identified in the house, and using things like duct tape or contact paper to block those areas so the children do not have access. And then also being diligent with wet mopping and damp dusting floors and surfaces. There are many leaded products that are coming into the US through the internet. And with funding cuts in import monitoring, that problem's probably going to get a lot worse. But regarding this clay pot, we did file a report through this safetyproducts.gov, which is a branch of the US Consumer Product Safety Commission. And with the parents' consent, I also referred them to Medical Legal Partnership that we have here at CHOP, as the home is not in compliance with lead certification laws, as I mentioned. As I do for all families, I gave a lot of sort of routine nutritional guidance and counseling on the importance of a healthy diet. And though in this child, there weren't any specific developmental concerns, we talked to families a lot about really the importance of fostering healthy development. So lots of talking to their children, reading, singing, stimulating play with blocks and puzzles, and really trying to limit as much screen time as possible. We also talked to families about thinking about enrolling their children in high quality preschool when they turn 3 years old. As I mentioned, this child was referred to childcare resources, and then the plan was to repeat her lead level at the 2-year well child visit per routine guidance. So I hope that gives you all sort of a flavor of what these visits look like. This is an example here. So as an example, I guess, here are the first 3 pages of the lead dust instruction packet that we provide families. So this was designed by colleagues of mine at the University of Washington, and then I was able to adapt them for our study. But this is basically what families are looking at with us as we ask them to prepare the reagents and as we guide them through the directions during the home visit to obtain these lead dust swabs. And so the instructions we give them, I think, are much more colorful and simpler to follow than the instructions that are actually provided by the manufacturer. Let's see here. So for this project, we used commercially available full disclosure, which is the name of the brand, qualitative lead dust swabs. These are colorimetric swabs, and so they actually change color in real time in the presence of lead once they're mixed with a chemical reagent. According to the wipe manufacturer, the wipe is likely to turn pink or red if lead exceeds 18 micrograms per deciliter per sample. And so to give you some context here, the new EPA guidance state that after abatement, the lead clearance standard is actually 40 micrograms per square footage on windowsills. And so this, this is able to detect actually pretty, I think, significant and low levels of lead that are relevant for home inspections. And these dust swabs that we use are actually EPA certified. Just to note, though, certain elements can interfere with the color change. So cadmium, silver, barium, mercury, and titanium, these are all heavy metals that can interfere with interpretation of results and can cause false color changes. Importantly, though, these wipes have been independently studied and verified in the lab using mass spectrometry, which is really the gold standard for lead quantification. And I'm happy to share the results of these studies with anyone at the end of the presentation if you're interested. But they have also been shown to be really good screening tools for lead, meaning that they have a high false positive rate at 32.6% and a low false negative rate at 13.8%, right? So a low chance of not turning red if there is indeed lead contamination. This picture shows an example of what our lead mitigation kits look like when families open their boxes. So they include 0-brand water pitchers with filter refills, lead dust swabs, cleaning solutions, paper towels, gloves, duct tape, a fun board book, and educational material. These are some other additional examples of potential lead hazards that we came across during, these were during 3 different home inspections, right? So you can see lots of deteriorating paint around this door frame. We can see chipping paint on the molding of the ceiling and the wall. And then this window sash shows chipping paint and a large amount of dust accumulation. These are very, pretty classic examples of things that we saw during the visits. Here's another example of lead dust sampling. So we can see significant chipping paint here along the banister and even the wall lining this stairwell. And then the swab that we obtained of this banister showing grade 2 to 3 sort of lead exposure, indicating high potential for lead. So you can see sort of dark orange, purplish red color change. And so if we go back to the scale here, it looks like sort of, if we interpret that together, like sort of a grade 2 or 3, these last 2 colors here. If you're, during these visits, we see a lot more environmental hazards than just lead. And so here are some examples of water damage and mold that we saw. Some molding lining a bathtub, and some mold in a living room ceiling, likely coming from some faulty plumbing, and then mold on the ceiling of a bathroom here. And my education doesn't really stop at lead. And so I am really able to provide families with a lot of sort of routine mold education, and in some cases, even referring families to L&I if I feel like the rental home is out of compliance, which the families always appreciate. So looking at the patient and participant characteristics at the end of the study. So the mean age of the patient or the participant enrollment was 1.42 years. The majority of participants enrolled in our study were Black, non-Hispanic, at 28.8%. 96.2% of families enrolled are enrolled in public insurance, and 79% live in homes built before 1970. The mean lead level in cohort B, so these are kids with low but detectable lead exposure, was 1.92. Here are the results of the virtual inspection, and this figure displays how often rooms in the virtual visit showed lead contamination. So the N value equals the number of times that room was inspected, and then the color gradient shows the potential lead hazards or defect that were identified. So the color gradient, with the color gradient, the darker colors indicate more hazards and the lighter indicates less hazards or less defects. So let's see here. So for example, if we look at the hallway, we inspected the hallway 7 times in 7 of the inspections. The majority of the hallway inspections found 1 defect indicated in this sort of light pinkish hue. And about a quarter of inspections, there were no defects in this sort of cream hue, and a small number showing 2 defects in this darker orangey red hue. The key takeaway from our virtual inspections was that high traffic rooms were inspected most often. It's not a terrible surprise, but things like the living room, kitchen, primary bedroom, and bathroom were inspected most often. Overall, potential lead hazards were found across all room types, and the basement I thought was notable for having the greatest density of defects, right? So though we only went into a basement and inspected a basement 5 times, in most cases, we found more than 1 lead hazard. As part of our initial intake process, we screened for various social drivers of health needs, including childcare, utilities, food, and housing. Referrals to community-based organizations were provided to all families who screened positive and indicated they were interested in resources. So in both cohorts, so we're looking at cohort A on the left, cohort B on the right, food insecurity ranked among the highest of all needs, but significantly higher in cohort B than in cohort A. And then interestingly, families with older children, so cohort B, show higher social drivers of health needs across all domains, excluding housing. So we thought those results were also noteworthy. A total of 15 families completed a 10-question knowledge test and had a mean score of 8.13 and 8.33 respectively. So a high baseline score and show no statistically significant change post-intervention. For this project, we used a shortened version of the Chicago Lead Knowledge Test, which is a validated 24-question survey designed to measure parental knowledge about childhood lead poisoning and prevention. So as mentioned earlier, beginning in 2020, Philadelphia began phasing in a new lead certification law by zip code that essentially required all rental properties built before 1978 to be certified as lead safe or lead free. So as part of this process, the landlord is required to hire a certified home lead inspection company to perform the inspection, and if needed, hire certified contractors to make the needed repairs. A lead-safe certificate is valid for 4 years, and a lead-free certificate has no expiration date. So we queried Open Data Philly, which is the city's official open data repository, to look at lead certification status in rental homes across the entire city and amongst our pilot project participants. And so the table on the left is lead certification status in rental homes across the entire city of Philadelphia. And on the right is of our study participants. And we found that 86% of rental homes in the city are lead certified, and 0.5% are not certified. 13% citywide are lead certification status has been expired. So it's exceeded that 4-year period. Interestingly, in our study group, of the 40 participants who live in rental homes and lived in a Philadelphia zip code, we saw much greater rates of not certified lead status. So in our group, we saw that 27.5% of participants had a not certified status versus, again, the citywide data of 0.5%. And so, of course, this raises the question of, well, what is demographically unique about our study cohort as compared to the city as a whole? And two obvious things jumped out to me. First is geography. And so obviously in this study, we're just looking at all of our study participants are coming from CHOP South Philly. And so patients are likely predominantly coming from surrounding neighborhoods in South and Southwest Philly. And so geography could influence this. And then number two, 96% of our patients are enrolled in Medicaid. And so perhaps children with Medicaid are just more likely to live in rental units that are not compliant with lead certification laws compared to Philadelphia as a whole. So we looked into this a little bit more. And so this is a map of Philadelphia looking at percentage of rental homes by zip code with expired or non-certified lead status. And in this map, the really light orange and yellow represent high percentage of expired or not certified lead status. And then the darker purple, of course, represents low levels. And so we can see really high rates, as high as between 15 and 20% in parts of West, Southwest Philadelphia, and North Philadelphia. And so I wish I should have done a side by side, but if we can remember in our mind's eye and compare this to the prior map where we were looking at rates of elevated lead level by zip code, there's really almost a direct correlation between the two, with the same 8 zip codes showing high rates of expired or non-certified lead certificates as those zip codes that have high rates of children who are lead exposed. In fact, about 1 in 5 rental homes in the highest risk zip codes are non-compliant with the existing lead certification laws. So we thought this was a really important finding and speaks a lot about environmental justice as well. When we surveyed families about their experience with the study, families, really 100% of families actually said they'd recommend the program to a friend or family member and felt that the lead kit and the educational materials helped to make their home lead safe. The majority felt that we were able to identify possible sources of lead during the visit and that their questions about childhood lead poisoning were answered. Here are a few sample quotes from participants from the study that were taken at the time of the survey. All of this post-participation feedback was really positive. I'll just read you the first one. An answer to the question of, did the video visit and lead kit give you education and resources so you could make your home lead safe? This family had written that, as a family, we have always been concerned about lead prevention, especially because they are doing so much work in the city and up our street. It was very beneficial to have been given the resources and education, and it helped us to relax a little bit because we tested places that were not high levels of lead. We also really appreciate the water filter because we have been looking into buying a lead filter prior to this program. So just briefly, the major challenges and limitations of this study, I felt that were difficulty with participant recruitment and retention. So as I mentioned briefly, we recruited 55 families, but only 27 actually completed the study, meaning that they completed the virtual home inspection. So that's a dropout rate of over 50%. It's not clear exactly why that is, but I think my general feeling is that families are really busy, and we have a lot of high risk families here, and so it's hard to get people on the phone, and it's hard to convince families that this is really that this is something that should rank highly on their sort of the most important needs for them, because again they have a lot going on in their day-to-day lives. To improve retention, we attempted to change our recruitment practices. So we changed some of the verbiage that we're using in recruitment. We changed the word from inspection, we changed it to tour to make it sound a little bit less official. We delayed sending lead kits until after the inspection, hopefully as leverage. And we even offered $15 cards as remuneration for families' times. None of these strategies meaningfully impacted recruitment or completion rates. And so we have some work to do and some reflection about how to improve those rates. As far as future directions, really, we'd like to expand beyond CHOP South Philadelphia to provide preventive lead education and resources really to all high-risk families living in Philadelphia. So some potential ways to do this would be to partner with other Philadelphia-based CHOP clinics, to work with our non-CHOP colleagues that are here in Philadelphia, and even OB clinics to recruit parents in the prenatal period. We would also like to partner with community organizations, for example, immigrant resettlement agencies, the Philadelphia's Lead and Healthy Homes program, the Department of Public Health, and even WIC. All of these would be potential community partnerships that we will be thinking about. But I will end it at that. Here are my references, and I also want to give a big shout out to Stephen Zacharinas, who was a huge help in terms of data interpretation, and Alex Northrop, a fantastic second-year resident who helped, again, with data interpretation and also helping me with some of these great and beautiful geospatial mapping images that I shared.